In this episode of EHA Unplugged, we will revisit a spotlight talk from EHA 2024. Dr. Kiran Tawana from Addenbrooke Hospital in Cambridge dives into the topic of hereditary hematological malignancies.
So the subject of my talk will be hereditary hematological malignancies, a new era of discovery in myelodysplasia and AML. So in brief, this talk will cover the discovery of the hereditary hematological malignancy syndromes, how we can recognize these in clinical practice, some key features about DDX41 variants, which are now the most prevalent germline variant recognized worldwide, as well as updates on the key transcription factor syndromes, RUNX1, GATA2, and CBP-alpha. I'll then go on to talk about disease evolution within families, in particular the important molecular insights we can gain from these case studies, and how we can integrate testing for germline variants into clinical practice with this amassing information. So hereditary hematological malignancy syndromes are syndromes where two or more cases of cytopenia and hematological malignancy occur within a family, and this is typically myelodysplasia and acute myeloid leukemia. They're thought to arise from pathogenic germline variants in genes typically regulating hematopoiesis, and they give rise to an autosomal dominant predisposition in the majority of cases. However, it's important to note that there is variable penetrance, with some syndromes associated with only 10% penetrance, whereas others have a higher risk of developing disease with over 80 or 90% penetrance. The latency of disease onset can differ significantly as well, with cases described as young as in infancy, while others develop disease over the age of 80 years. As the germline landscape has evolved over the last decade or so, these cases are now thought to account for 5 to 15% of all myelodysplasia and AML. It's essential we recognize these syndromes because it enables us to perform accurate risk assessment in patients, to personalize treatment, in particular modifying toxicities from modalities such as radiotherapy, and to initiate cascade testing of family members, particularly where we're considering related donor stem cell transplantation. We must also be mindful that these patients are at risk of secondary cancers, and surveillance is essential. The germline field really began in 1999 with the identification of germline RUNX1 variants in 6 families presenting with thrombocytopenia and myelodysplasia AML. Since then, a number of genes have been described in the landscape, and they can broadly be categorized according to the WHO 2016 classification. So that is syndromes which predispose to myeloid malignancies alone, including the CBP-alpha variants and DDX41 variants, those associated with platelet dysfunction, in particular RUNX1, ANCAR-D26 and ETV6, and those which are associated with other organ dysfunction, including GATA2 deficiency and the telomeropathies. I'd just like to mention several of the syndromes which have been discovered in recent years, and this includes ERCC6L2 variants, which is an autosomal recessive disorder, giving rise to early onset myelodysplasia and high-risk AML. Quite often, the patients will have a prodromal period of cytopenias or bone marrow failure, and it's essential to recognize them during this early stage, as predisposition to leukemia is often associated with adverse outcomes. DHX34 variants were first described by Dr. Machin et al. In 2020, and this is a nonsense-mediated decay gene which gave rise to the onset of cytopenias and myeloid malignancy in several families, with ages ranging from 2 to over 20 years. Germline variants in ERG were recently described as a late-breaking abstract at ASH, and this is a known oncogene. Interestingly, individuals with this syndrome harbored typical crossover features between RUNX1 and GATA2 deficiency, presenting with thrombocytopenia, myeloid malignancy, as well as lymphedema. So the majority of patients with myelodysplasia and AML will have next-generation sequencing performed at diagnosis, and quite typically with the germline variants, we see that the variant allele frequency remains stable throughout the disease course, irrespective of disease or remission status. There are important exceptions to this rule, and this includes the SAM-D9 and D9L syndromes. In these cases, the germline variant can be typically lost through acquisition of monosomy 7 or deletion of chromosome 7q, the location of SAM-D9 and D9L. Alternatively, patients may undergo uniparental disomy events of the wild-type allele, leading to loss of the germline allele, and this actually leads to recovery of bone marrow function. Whilst the majority of germline variants are inherited, de novo events can occur, in particularly post-zygotic events, and these can lead to mosaicism with, again, typically low variant allele frequencies, and this has been described in Li-Fraumeni syndrome. So how can we recognize these disorders in clinical practice? Well, it's important to maintain a high index of clinical suspicion and be aware of the variable signs and symptoms. There can be key morphological features, including severe megakaryocytic dysplasia, particularly with the thrombocytopenia syndromes, as well as GATA2 deficiency. And it's important to ask a personal and family history, which may only be positive in about 40% of cases. However, symptoms such as cytopenias, myelodysplasia, acute leukemias, bleeding propensity should all raise a red flag. The majority of patients with germline variants present at a young age, typically less than 50 years, with GATA2 cases peaking in the first or second decade. The majority of cases with CBP alpha variants will present before the age of 40, and the average age of onset for RUNX1 variants is in the late 30s, although there is a peak slightly later in life. With the bone marrow failure syndromes, we see that SAM-D9 and D9L are really restricted to younger age groups, and the telomeropathies can occur slightly later. However, there's one syndrome that stands apart from the rest, and that is DDX41, where patients typically have a peak age of onset beyond 65. So DDX41 variants represented a novel molecular entity back in 2015 when they were first described. This is a gene encoding an RNA helicase, but it also has an important role in immune function, in particular in the STING pathway, which mediates responses to intracellular pathogens. The majority of patients presented with myelodysplasia and AML with a median age of onset of 65. Typically, patients had a hypocellular marrow with erythroid dysplasia, and the majority of cases had a normal karyotype. Interestingly, somatic DDX41 variants were acquired in over 50% of cases, highlighting how important biallelic disruption was for disease onset. Since then, there have been multiple studies mapping the landscape of both germline and somatic DDX41 variants. And what we see in the germline setting is that there are often several key hotspots, and these define founder mutations. Somatic DDX41 variants can occur throughout the gene, but typically target the R525 codon. So while we know these variants occur in the general population, a recent study sought to assess the prevalence of germline DDX41 variants, and they studied over 450,000 adults of European and non-European descent through UK Biobank data. They found that germline variants were detected in 1 in 129 cases. However, when criteria of pathogenicity were used, the figure actually dropped to 1 in 430. This is really quite a high figure for an autosomal dominant predisposition gene. However, DDX41 variants only give rise to about 2 to 4% of all MDS and AML. So studies have focused on looking at which factors are really associated with the onset of malignancy. We know that truncating variants are thought to have a higher risk of malignancy onset compared to missense and start-loss mutations. There's also a high preponderance for males. In the original study by Pulprasert et al., 95% of cases with MDS and AML were male. Subsequent studies have suggested that the figure is closer to a ratio of 3 to 1. Interestingly, with DDX41, this is a late onset malignancy. However, clonal hematopoiesis is not observed in these cases, and the key driver of disease is actually a somatic DDX41 variant, which is now thought to arise in about 80% of cases. Additional mutations do occur in CUX1 and GNAS, also in RUNX1, ASXL1 and TP53, but there's no clearly defined molecular signature with the exception of this somatic variant. Multiple studies have elucidated the functions of DDX41, which include mRNA splicing, STING activation, as well as RNA processing. However, we're yet to answer the key question, which is why are patients presenting so late? So in contrast to DDX41, the transcription factor syndromes have more clearly defined profiles. We can see here with germline RUNX1 variants, the penetrance approaches 50%, with the majority of cases developing myelodysplasia and AML. There is also an important but small number of cases presenting with lymphoid malignancy, including TALL, BALL, and non-Hodgkin's lymphoma. We now know that the majority of RUNX1 carriers do develop clonal hematopoiesis, which increases with age. The variants identified are TET2, BCOR, and DNMT3A, and disease transformation is associated with the acquisition of a somatic RUNX1 variant associated with other cytogenetic changes, PHF6 variants, and BCOR variants. With GATA2, the penetrance is over 80%, and the majority of cases develop myelodysplasia. About 10 to 15% of cases will present with AML. We know that clonal hematopoiesis also occurs with GATA2 carriers, however, it's thought to be less common than with RUNX1, and the dominant feature is usually asymptomatic carriage of an ASXL1 variant. Disease transformation is associated with the acquisition of monosomy 7, deletion of 7q, and interestingly, this derivative unbalanced translocation between chromosome 1q and 7q, which appears to be enriched in the GATA2 deficiency syndromes. Germline CBP alpha variants also have a very high penetrance, which increases with age, with over 80% of cases developing AML de novo. I'll go on to talk about this syndrome now. The germline CBP alpha variants were first identified back in 2004 when two siblings presented to St Bartholomew's Hospital back in 2003. They were aged 18 and 30 and presented within a matter of weeks with AML M2. On further questioning, their father had also developed AML at the age of 10, and all three individuals shared a germline N-terminal CBP alpha variant. In the years that followed, further CBP alpha pedigrees were described, and this prompted us to commence a collaborative study to characterize these families in more detail. We found that the germline mutations were all N-terminal frameshift variants, which preceded the internal P30 start codon. All tumours also acquired a somatic CBP alpha variant, which was located in the C-terminal, particularly targeting this lysine 313 residue, and these were typically in-frame insertions or deletions. When we mapped out the clinical events across this cohort, there was a striking observation, and that was that individuals had multiple episodes of disease, often spanning a time course of decades. The cumulative incidence of relapse was 56% at 10 years, and relapses often occurred late, with a median time to relapse of 27 months, but as late as 167 months. So this prompted us to study the relapse samples, and what we found was that the somatic C-terminal mutation actually differed at relapse in 5 out of 6 cases. And this phenomenon was observed as early as 13 months following the diagnostic presentation, or as late as 14 years. So further sequencing of these pedigrees using whole exome sequencing and deep molecular sequencing identified that none of these C-terminal variants were actually present in the diagnostic sample, confirming that they were unique leukemic episodes. The overall survival of familial CBP alpha AML was favorable compared to even sporadic double mutant AML, which is thought to be associated with good outcomes. And this was particularly surprising considering that there are a higher number of relapses. So when we assessed the relapse post-survival, we found the answer to this. The median relapse post-survival was 8 years compared to 16 months in sporadic subtypes, showing that relapse episodes actually retained chemosensitivity with favorable outcomes. So in summary, this represents a unique pattern of disease evolution which is thought to arise due to the high penetrance of N-terminal germline variants. Relapses are caused by new leukemic episodes which often occur late. And we see favourable responses to second-line therapies and outcomes superior to even sporadic, say, CBP alpha double mutant AML. However, the story continues. In the years that followed, germline C-terminal CBP alpha variants were actually described, but these were different to the variants which accompanied the N-terminal frameshift lesions. They're instead missense or frameshift lesions that were located in the leucine zipper domain. And interestingly, they're associated with a far reduced penetrance with only about 40 to 50% of carriers developing disease. Disease onset occurred younger on in life, as expected, and the outcomes are still waiting to be fully characterized, but suggest that they are inferior to the germline N-terminal variants. So whilst it's important to look at larger family studies, we also gain important insights by looking at case studies. And this was a particular family that was referred to us from Hungary, where the mother was an asymptomatic carrier of a nonsense RUNX1 variant. She had 4 daughters who all carried the same variant, and interestingly, they all harboured the JAK2 haplotype, which is found in 25 to 40% of European individuals and predisposes to the risk of myeloproliferative disorders harbouring the JAK2 V617F variant. We performed whole exome sequencing across all 4 children because, unfortunately, 3 daughters developed AML and the 3rd sibling had MDS. In the siblings that developed AML, we found acquisition of an SH2B3 variant associated with uniparental disomy, increasing the mutant allele burden. The second twin developed a JAK2 V617F mutation, again with uniparental disomy. And the 4th sibling, who presented later, again at the age of 5 years of age, had acquired a JAK2 V617F mutation. So we have 3 siblings with AML all presenting at the age of 5 and acquiring JAK-STAT variants in the context of a 46-1 haplotype. So this really suggests that pathogenic germline variants and host genetic features can interact to influence somatic mutation acquisition. So this phenomenon of convergent evolution isn't restricted to RUNX1 pedigrees. We've also seen it occur in GATA2 pedigrees, and this was one such pedigree, where we studied 3 cousins. 2 cousins presented with high-risk MDS and AML, and unfortunately died with complications post-stem cell transplantation, but they both harboured this somatic ASXL1 variant. The 3rd cousin presented over 10 years later, again with the same ASXL1 variant, but at a lower variant allele frequency, and she only had mild neutropenia. Clinical surveillance was performed for this individual over a period of time. And this longitudinal monitoring actually allowed one of our colleagues, Dr. Al-Sarahi, to actually study the mechanisms of penetrance in this case. In the earlier years, she observed monoallelic expression of the mutant GATA2 allele, which coincided with more severe monocytopenia and neutropenia. As time progressed, interestingly, the counts recovered, and this coincided with recovery of wild-type GATA2 expression. She tried to investigate the reasons for this and actually found that this was due to increased methylation of the wild-type allele promoter, leading to selective expression of the mutant allele. Interestingly, with this higher mutant expression, there was a higher ASXL1 variant allele frequency, which correlated with disease severity. So this really suggests that clonal evolution and disease manifestations are governed by mutant allele expression. So as we've learnt a great deal over the years with germline variants, it's important to think about how we can optimize testing of patients in clinical pathways. Now, when patients present with high-risk MDS and AML, they're often considered for stem cell transplantation within 3 to 4 months of presentation. They will undergo tumor testing, and then if suspicious variants are identified, they will need confirmatory germline testing, followed by related donor testing if they find a suitable match. The key issues here are that the culture of skin fibroblasts can take up to 4 to 6 weeks and leads to significant delays in testing. So we would therefore advocate that if a hereditary hematological malignancy syndrome is suspected, a skin biopsy should be taken at diagnosis, preferably with the diagnostic trophine biopsy, and sent for culture of skin fibroblasts to prevent delays later on. We're fortunate in the UK to have access to whole genome sequencing, which can be performed upfront. However, where germline results are unavailable and time is limited, we would advocate parallel testing of both the patient and the related donor to exclude an underlying germline predisposition syndrome. Now, we have a number of modalities to test myelodysplasia and AML. However, we do need to ensure that our assays are comprehensively set up to identify all germline variants, and this includes non-coding lesions, synonymous variants, and copy number variants. We know that non-coding lesions can account for up to 10% of GATA2 cases and are often not included in typical next-generation sequencing assays. Synonymous variants can be very difficult to interpret without further studies, and copy number variants, again, require optimization of either SNP arrays or FISH panels to ensure we detect these either single exon or partial allelic deletions. As we identify more and more genes, it's essential that we update our gene panels accordingly. However, even with thorough, comprehensive genetic testing, we know that 40% of families remain uncharacterized. So, in conclusion, the assessment of germline predisposition is now an integral component of genetic testing in myeloid malignancies. Inter- and intrafamilial disease evolution highlights new genetic associations and advances our understanding of disease. It's a dynamic field and requires optimization and standardization of testing. And as clinicians, we must maintain clinical vigilance and consider collaborations with research groups to advance further developments and discovery. Thank you.